Hello friends. Today we are going to discuss on some aspects of lung cancer, especially lung cancer in India, that is treated by you and me. Lung cancer is a very common cancer being diagnosed in our country. We are diagnosing nearly 1 lakh cases every year. And the people who commonly diagnose lung cancer are physicians and pulmonologists. We all know that the common symptoms of lung cancer include cough, dyspnea, hemoptysis, pain especially in the shoulder or the chest or sometimes in the upper arm, and sometimes vague symptoms like difficulty in swallowing, change in voice, and at times low-grade fever and weight loss. Unfortunately, very commonly, especially in the peripheries, most patients who may have a lung cancer are actually treated on the lines of tuberculosis without extensive workup. Any patient who has prolonged hemoptysis, massive hemoptysis, or prolonged cough or dysphagia should have at least an X-ray chest of the abdomen, at times a CT scan of the chest, and if need be, a bronchoscopy. The treatment of lung cancer has reached new advances. For very early stage disease, the treatment of choice remains surgery. For a select few patients who are fit enough for a surgery but because of age or comorbidities are not able to undergo surgery, stereotactic body radiation therapy is now giving results equivalent to surgery. Most of our patients are diagnosed in locally advanced cases where radiation along with chemotherapy is the treatment of choice. What has changed dramatically is how we treat patients with advanced lung cancer. 15 years ago, the expected survival for these patients would have been in a matter of a few months. However, that has changed. We now subject all our lung cancer patients, especially those with non-small cell lung cancer, especially with non-small cell and non-squamous cell lung cancer, to an array of molecular genetic tests, not just pathological tests. And especially in adenocarcinoma, nearly 1 in 3 of these patients may harbor a targetable mutation like an EGFR mutation or an ALK mutation, ROS mutation, and the number of these mutations, the list of mutations is ever increasing. And these patients who have a targetable mutation are now subjected to oral targeted therapy, drugs like gefitinib, erlotinib, osimertinib, crizotinib, etc. And we've seen through phase 3 research trials, through our own experience, that these patients, when treated with targeted therapies, not only do better than those patients who receive chemotherapy, but these targeted therapies are actually also safer. And now we have our own experience to say that these patients with advanced lung cancer who are being treated with targeted therapy are actually living for as long as 3.5 years on an average. Contrast this with the expected 1 year survival, which was seen nearly a decade back. Immunotherapy has brought about a radical shift in the paradigm of lung cancer treatment. For those patients who do not harbor a targetable mutation, now research has shown that in the first line setting, when we combine immunotherapy along with chemotherapy, or in certain cases where PD-L1 is very highly positive, give immunotherapy as a monotherapy, patients are living long. In fact, one of the trials suggested that patients who have a PD-L1, which is a biomarker for immunotherapy response, of more than 50%, patients were lived as long as 30 months on immunotherapy. And this is a dramatic survival in this age. One of the most frustrating subtypes of lung cancer that we encounter frequently is small cell cancer of the lung. It's typically seen in patients who smoke. However, we do have an occasional patient who's never smoked and yet has been diagnosed with small cell lung cancer. These cancers are known to rapidly progress, but they're also very chemo and radiation sensitive. Nearly 20% of lung cancers are small cell lung cancers. We traditionally divide them into 2 stages. Limited stage disease, where the disease is confined to one part of the lung or at most to the adjoining lymph nodes, which are traditionally treated with a combination of radiation therapy and chemotherapy. However, it's the extensive stage disease where the disease has spread outside the confines of a single lung to the opposite lung, to the pleura, or to distant organs, which has been very frustrating to treat. For nearly 30 years, the backbone of treatment was a combination of two chemotherapeutic drugs, carboplatin or cisplatin with etoposide, with no improvement despite the radical advances in oncology. However, a couple of years back, that changed. Now there is data to suggest that if you combine immunotherapy to these chemotherapeutic drugs, not only there is an increase in response rates and progression-free survival, for the first time in many decades, we are actually seeing that this new combination makes patients live longer as compared to when they are treated with chemotherapy alone. This is opening up new avenues for treatment of patients with this disease, and this is changing how we are approaching this disease in our clinic. One of the key risk factors for lung cancer has been smoking. We know that nearly 40% of our population uses tobacco in one form or the other. And while predominant tobacco consumption has been through oral tobacco like gutka and pan masala, we have a substantial number of patients who are smoking, including those who smoke cigarettes and bidis. We know that the quantum of smoking is directly linked to the risk of lung cancer. The higher you smoke, the greater your risk. And in fact, even cessation of smoking does not immediately lead to normalization of risk. It takes nearly 20 years for a risk to reduce to that of a non-smoker for a patient who's ever smoked. Other than smoking, there are other risk factors. It seems that external environmental pollution is also a carcinogen. However, the relative risks are still small, and so is indoor pollution. There are other risk factors, including chronic trauma or chronic inflammation, and we've had patients who have suffered from chronic tuberculosis who then subsequently developed a lung cancer. What is very important to understand for not only clinicians but also us oncologists is that a lot of our patients who are eventually diagnosed with lung cancer may be non-smokers, and therefore a lack of smoking history does not entirely rule out the possibility of lung cancer. How do you diagnose lung cancer? Obviously, whenever you have patients with symptoms which could possibly be because of lung cancer, which include cough, dyspnea, hemoptysis, change in voice, or pain, those are the cases where an active diagnostic workup should be done. Imaging is one of the key modalities, and while one of the first go-to image has been X-ray in our country, a lot of times you really need a CT scan, a thin slice CT scan of the chest to actually get a better idea of what we are dealing with. A lot of times what is needed is a bronchoscopy, especially for those findings on a CT scan which are more central. And a bronchoscopy not only aids in the diagnosis by visual confirmation of a growth, it also helps in conducting a biopsy and then which is then subjected to a histopathological examination for not only confirmation of the cancer but also confirmation of the subtype of cancer. A lot of times, clinicians encounter what we call as a solitary pulmonary nodule. These are findings where there are lesions which are less than 3 cm in size and typically not associated with any symptom and incidentally diagnosed on a CT scan. It's very important to appropriately work up these patients who have a solitary pulmonary nodule. A clinician has to have a very high index of suspicion, especially for larger nodules, nodules which are more than 1 cm in size, nodules which have spiculated margins, nodules which have eccentric calcification, or nodules which seem to be growing on serial CTs. These are the nodules which should be subjected to a biopsy and where a lung cancer diagnosis should be suspected. Often, once we've made the diagnosis, we do a staging workup, and a backbone of our staging workup has been a PET scan of the whole body. A PET CT is one of the key modalities for completion of the staging workup for lung cancer. It not only aids in diagnosis or spread of lung cancer to potentially the contralateral lung, to the lymph nodes, to the liver, to the bone, and sometimes to other parts of the body. In fact, PET CT may also be crucial in working up a case of a solitary pulmonary nodule where the risk of malignancy is intermediate. One of the key questions that we face in India is how do you differentiate tuberculosis from a malignancy of the lung? Unfortunately, some of the symptoms of malignancy are also those of tuberculosis, which include cough, productive at times, breathlessness, weight loss, and lack of appetite. I think our clinicians play a key role in making the right diagnosis. I think it's imperative that we do the right imaging for either of these diseases, which should not be limited to just an X-ray, but I think wherever possible, a CT chest should be performed. Two, we have to have a definitive confirmation of pulmonary tuberculosis, and often that can be done through a sputum examination. Sometimes when sputum examination does not come out as positive for tuberculosis and yet the index of suspicion is high, a bronchoscopy should be performed, and occasionally a CT guided biopsy may also be needed. What's very important is that not to label anybody who's not been correctly diagnosed as pulmonary tuberculosis, because a delay in diagnosis of malignancy can lead to not only increase in stage of the cancer of the lung, but may also affect negatively the outcomes in terms of cure rates. The second important point that I really often tell my pulmonology friends is that if you started a person on anti-tubercular medication, it's very important to see how that person is performing. Most of the times, you would see a rapid response, rapid improvement in clinical symptoms after the initiation of anti-tubercular medicines. And if you haven't seen, I think it's very important that you question the diagnosis again, or increasingly in India, rule out multi-drug resistant tuberculosis. One of the questions that is often asked to me is, who treats a patient? And I feel it's a partnership of not only the oncologist but also the general practitioner who are key in treating the patient. I know how to treat a cancer. My surgical colleague can perform a surgery, a radiation oncology colleague can deliver the radiation therapy, and I can deliver the necessary chemotherapy, immunotherapy or target therapy. But these patients with lung cancer are often older individuals. They have a lot of comorbidities, which not only include hypertension, diabetes, but also hypothyroidism. Often they are diagnosed with their comorbid illnesses during the diagnosis or during treatment. It is you, our friends in the general practice, who actually help maintain the health of the patient. And that ensures that we are able to deliver the cancer treatment on a timely basis. You play a key role in maintaining the blood sugars of the patient, maintaining the blood pressures of the patient, ensuring that the patient takes his other comorbid illnesses on a timely basis, and which helps not only that we give the treatment appropriately but in the right doses. General practitioners play a huge role not only during treatment but also during follow-up. These patients come to us for follow-up on a 3-monthly basis, where we conduct a physical examination and at times imaging. But they stay in regular touch with their general practitioners. And I feel it's not only their maintenance of general health, maintaining their fitness levels, ensuring that their vitals are under control, but also general practitioners play a key role in early diagnosis of a recurrence, in timely referral of these patients when you have suspicious symptoms like reappearance of a prolonged cough, a reappearance of a severe pain or unexplained weight loss. What are the cure rates for patients suffering from lung cancer? We know that patients with an early stage disease, patients with stage 1 and stage 2 lung cancers can have a cure rate which is as high as 60 to 80%. While these are subjected to curative intent treatment, we typically take at least 3 to 5 years before we declare the patient has been cured. For patients with more advanced stages, that is stage 3 disease, the cure rates are in the range of around 40 to 50%. Again, cure is declared only once the patient has been cancer-free for 5 years. However, typically, once the treatment is over, we subject these patients to an imaging, and if the patient is in remission, the technical word that is used is remission. It's very important to correctly follow up these patients with earlier stage disease. And often, I would ask my patients with lung cancer with early stage disease to visit me in my OPD on a 3-monthly basis, where I subject them to a history, a clinical examination, and at times regular imaging, which includes a CT scan of the chest and abdomen on a 3 to 6 monthly basis. Often these patients will have some symptoms which may warrant an earlier imaging, in which case we subject them to a CT of the appropriate part on a more frequent basis. These patients would know my schedule. These patients would be in touch with me, and therefore the schedule is available to them on how they need to follow up with me. However, it's very important that they stay in touch with their family physician, their general physician, because it's the general physician or the family physician which ensures that the patient stays in the peak of their health even when the treatment of cancer has been over. We often ask our general physician friends to have a very high index of suspicion for a recurrence, and therefore any of these patients who are in remission for their lung cancer and are on follow-up, if they present with any suspicious symptom like a prolonged cough, a hemoptysis episode, a sudden onset headache or a backache, or an unexplained fever or weight loss or loss of appetite, these could be symptoms of a recurrence, where I feel you should feel free to conduct an imaging, which could be a CT of the chest or abdomen or of the MRI of the brain. Because it's only timely suspicion and timely diagnosis which is going to ensure that if a recurrence has happened, we diagnose it and we treat it accordingly. It's also very important that these patients who are either on treatment or who have actually entered remission and are on follow-up be treated aggressively for any of their comorbid illnesses. So there's no need to slacken on the tired glycemic control or the tired blood pressure control that you would otherwise institute for a patient who does not have a cancer. You play a key role in maintaining the health of the patient, and control of comorbid illnesses and timely diagnosis of a recurrence go a long way in ensuring that the patients continue to remain in the peak of their health. In the end, thank you for listening to me, and let's strengthen this partnership and ensure that our patients are diagnosed timely and are treated in a fashion which not only ensures that they live longer, but also that they live better. Thank you once again.